What is gastroparesis? Because gastroparesis is first bothersome symptoms, but together with delayed gastric emptying and in the absence of a mechanical obstruction. And all the three are important. Because what we sometimes see is that people tend to focus most on the delayed gastric emptying, but not everyone with delayed gastric emptying actually has gastroparesis. So what are the symptoms of gastroparesis? This can be nausea, vomiting, fullness, early satiety, bloating, and epigastric pain, as you all know very well. However, I really want to emphasize that nausea and vomiting are the cardinal symptoms of gastroparesis. More than 95% of patients have nausea and vomiting, true gastroparesis patients, and this was also endorsed in the consensus. Also, when we look at the correlation between the improvement of gastric emptying and of symptoms with these drugs that you see here, prokinetics including cisapride, domperidone, and so on, there is no correlation. So you will improve symptoms, and you will improve to some extent gastric emptying, but these are not correlated. And finally, a very important study published in Gastro this year, it looked at the consistency of delayed gastric emptying. So about 1,000 patients with upper GI symptoms were investigated. 3/4 of them had delayed gastric emptying, 1/4 did not have delayed gastric emptying. So these were defined as functional dyspepsia. And they were investigated again after 1 year, and surprisingly, 40% of the so-called gastroparesis patients now had normal gastric emptying. And 40% of those with normal emptying actually had delayed gastric emptying. Again, emphasizing that symptoms and delayed emptying is not the same. This is the graphic representation where in red you see the symptoms, in blue is the emptying. So the emptying changes, but the symptoms don't. So what is the conclusion of this? Is gastroparesis a dead-end street after all, and should we really give up on gastroparesis? Well, I don't think so, and also Jan Tak didn't think so in this editorial, but I do think so that you can only make a proper diagnosis of gastroparesis in patients with severe nausea and vomiting in the presence of a delayed gastric emptying. So how can we treat patients with gastroparesis? If you look at the guidelines, this can be with dietary advice, frequent small meals, low fiber meals. There is some indications for medical therapy. Can we do gastric electrical stimulation? And can we use endoscopic treatment? So I will briefly discuss some of these. So in terms of medical therapy such as prokinetics, this is a meta-analysis showing that prokinetics are indeed effective. However, most of these studies are old, most of these studies are low quality, high risk of publication bias, and also there is a problem with adverse effects. And you all know this very well. Extrapyramidal symptoms with metoclopramide, clabopride, alizapride, and QT prolongation with domperidone. So we don't have a lot of efficacious prokinetics which can be used long-term. And then finally, let's move to gastric POEM. And in a few minutes, you will see a live demonstration of gastric POEM by David Tate. But in just a few words, what happens is it's similar to POEM, what you would do in the esophagus, but here you would create a tunnel via the antrum across the pylorus. You do a pyloromyotomy, you come back and you close the defect of the mucosal incision. So the rationale to do this is the same as a pyloric dilatation. It's the same as intrapyloric Botox injection. We could maybe improve the delayed gastric emptying and symptoms by decreasing the resistance at the level of the pylorus. Does gastric POEM work? Well, I'm repeating my story. There are excellent results in open label studies. If you look at clinical response rates and improvement in gastric emptying, 85% response, which is of course great. In a very recent prospective study, including 5 highly specialized centers, the message is a bit less positive. 80 gastroparesis patients refractory to conventional treatment, so there is a selection, were followed over 1 year, and you see that the success rates, both at 1 month and at 12 months, is about 50%. Again, this is not a placebo-controlled trial, it's not a sham-controlled trial. If you look at the predictors of success, the symptoms come in. So those with severe nausea and vomiting are more likely to respond. Those with severely delayed gastric emptying are also more likely to respond. So not just a 10% retention at 4 hours, but really 20% retention at 4 hours. And also those who have a treatment success at 1 month. So this means if you don't have treatment success at 1 month, probably they also will not be better if you wait longer. So this was the literature until today. Many open label studies showing good success, but no controlled studies. I'm showing you one, this is just showing you that if you don't have success after 1 month, this is the dashed line, you will not have it at 12 months either. So I'm showing you this study, which has not been presented yet, has not been published yet, but it will be presented at the UEG week in actually this weekend. It's a study from the Czech Republic where actually, to the best of my knowledge, this is the first available sham control study in GPOM, single-blinded in 41 patients. So 11 idiopathic, 13 surgical patients, and 17 patients with diabetes. Inclusion based on severely enough symptoms based on a GCSI and delayed gastric emptying. Primary endpoint a bit different from the previous ones, but 50% decrease in GCSI at 6 months, which is quite a high hurdle to get to. And the presentation at UEGW will be the interim report of 36 of these 41 patients. And what they found was actually a treatment success of about 75% with GPO, compared to 18% with sham. And this was at 6 months. So a clear difference between sham treatment and GPOM treatment. And also in terms of gastric emptying, a 22% improvement of gastric emptying compared to, there was an improvement from 22% retention at baseline, so severely delayed gastric emptying, to 7% at 6 months, no difference with placebo. So this is actually a very encouraging study, and we really need these data before we can embark on doing GPOM in patients with gastroparesis. Then patients who had sham treatment were offered crossover to open label crossover GPOM.
So now the patient's in front of us. You have a normal endoscopy, a normal esophagram, but he complains of dysphagia. Can we stop here? Is there a functional problem? Do we suspect there is nothing really underlying here? Is a manometry really necessary? And I illustrate the necessity of a manometry here with a very small but interesting case series, where an upper endoscopy and an esophagogram was performed in patients with type 1, type 2, and type 3 achalasia. And it's really important to see that certainly in the type 2 and 3 achalasia, there is a large percentage of patients that really have normal findings. So yes, it is necessary to do an additional test, being the manometry, where a catheter with pressure sensors is introduced through the nose and through the both sphincter, the upper and the lower esophageal sphincter. So here the fourth version of the Chicago classification says, really manometry is not only the gold standard anymore, we really need more evidence by performing, for example, an endoflip procedure or by performing a time-barren esophagram to really determine if there's really a problem going on to the lower esophageal sphincter or not, because this is, of course, very important for the treatment of the patient. Is it an artifact or is it real?